Hi folks, I'm Dr. Chris Novak. I'm a pediatrician and a RIME pre-clerkship educator. This podcast will present an overview of adverse childhood experiences, also referred to as ACEs. I have no relevant financial disclosures and have taken appropriate steps for copyright. Before we start, a note. Child abuse and maltreatment is extremely common. Many of us have experienced or have been exposed to child maltreatment in our lifetime. Some topics discussed in this podcast may be triggering for learners, so please take care. There are resources available from the Student Advocacy and Wellness Hub and the AMA Physician and Family Support Program if you need support. After listening to this podcast, learners should be able to, number 1, define adverse childhood experiences. Number 2, describe the potential long-term physical and mental health impacts of ACEs. Number 3, identify ways to prevent or mitigate the impacts of ACEs. Of note, trauma-informed care will be taught in more detail elsewhere in the curriculum. ACEs are defined as potentially traumatic events that occur in childhood. While there are many events that could be considered adverse experiences, in most studies examining the impacts of ACEs, 10 items are identified in 3 categories. These include abuse experienced by the individual, including physical, emotional, and sexual abuse; neglect experienced by the individual, including physical and emotional neglect; and household challenges experienced by the individual's parents or caregivers, including mental illness, a parent being treated violently, divorce, an incarcerated relative, or family substance abuse. ACEs lead to significant stress in childhood. While life stressors do not always have negative consequences, without a supportive environment, they can have a significant impact on a child's development. Stress is defined as tolerable stress when there are supportive, caring adults that can maintain a safe environment and help children cope by ensuring their physical and emotional responses to serious events remain tolerable. In contrast, toxic stress occurs when children do not receive support from caring adults. Toxic stress may be frequent or chronic, and in the absence of relationships that buffer the impact of stress, this can impact brain development. ACEs are extremely common. An American study found that 64% of adults had experienced at least one ACE during childhood, while 17% have experienced 4 or more types of ACEs. The first major study in ACEs was published in 1998 by Felitti and Anda. This study surveyed over 9,000 adults and compared their history of ACEs to their current health status. The survey showed a striking dose-response curve with increasing rates of multiple health conditions as the number of ACEs increased. This included mental health conditions such as depression, suicide, and substance use, as well as other conditions such as obesity, ischemic heart disease, COPD, and cancer. Subsequent research has found an association with kidney disease, diabetes, unemployment, low educational attainment, and poor access to healthcare. The factors explaining these health outcomes is complex and include biomedical, psychosocial, and structural factors. A growing body of evidence shows how toxic stress can impact the nervous, endocrine, and immune system, and even affect the structure of DNA through epigenetic changes. A child's brain has an incredible potential for neuroplasticity where the brain can be rewired. While this plasticity leads to incredible opportunities for learning and development, it can also be negatively impacted by adverse experiences. Chronic toxic stress activates the body's stress response and over time can change neural networks in the brain. One potential consequence is a reduced threshold for activating the stress response. This can trigger a more frequent or prolonged stress response that persists long after a threat has passed. This toxic stress can have a significant impact on child development and predispose them to mental health conditions. Furthermore, ACEs impact the whole family unit, and parents and caregivers in a stressful environment may also have reduced capacity to support a child through these stressful experiences. The ACEs study hypothesized that childhood trauma predisposes individuals to risk behaviors such as tobacco and substance use, which may also lead to long-term physical health concerns. Finally, structural factors such as racism and intergenerational trauma have a huge impact on the incidence and outcomes of ACEs. With such a complex problem, there are no easy solutions. However, there are many things that clinicians can do to support individuals with a history of ACEs and trauma, as well as to advocate for systemic change. There is some controversy about whether or not we should be doing universal screening for ACEs in primary care. Some clinicians do this and advocate that it helps them better support their patients. In contrast, a systematic review found little evidence to support universal screening and wrote the conclusion, quote, "Screening without appropriate office-based guidance and supported linkages to community resources appears to have limited evidence of benefit and may be potentially harmful." Whether or not you adopt screening in your practice, if a patient or family discloses adverse experiences or has symptoms that may be related to trauma, it may be valuable to further explore this with a detailed social history. Given the high incidence of ACEs and trauma, a trauma-informed care approach is recommended for all patients. Trauma-informed care is defined as medical care in which all parties involved assess, recognize, and respond to the effect of traumatic stress in children, caregivers, and healthcare providers. This will be covered in more detail elsewhere in the curriculum. On an individual level, clinicians can support all families by promoting positive childhood experiences and early relational health. Positive childhood experiences include being able to confide in a safe adult about problems, as well as receive support from the community, including school, friends, and other networks. Research has shown that these positive childhood experiences can mitigate the impact of ACEs. Clinicians can counsel parents on positive parenting strategies that promote relational health. You can learn more about this in the Canadian Pediatric Society Guideline From ACEs to Early Relational Health. If you recognize that parents are experiencing challenges, you can refer them to different supports, including a family physician, mental health treatment, substance use programs, supports for intimate partner violence, or social work. Finally, on a societal level, physicians can advocate for social changes that may prevent ACEs from occurring in the first place. Strategies promoted by the CDC include strengthening economic supports for families, such as a child tax credit, childcare supports, or living wages. Public education campaigns can promote social norms that protect against violence and reduce the stigma around seeking help. Early childhood development programs, such as healthcare provider home visits, high-quality childcare, and preschool can help promote positive childhood experiences and healthy development. Connecting at-risk youth to caring adults and mentors, such as teachers, coaches, or big brothers, big sisters, can also help mitigate the impacts of ACEs. So, let's wrap up with a few key take-home points. Number 1. Adverse childhood experiences include abuse, neglect, and household challenges. Number 2. ACEs are associated with significant long-term health impacts, including mental and physical health concerns. Number 3. Physicians should employ a trauma-informed approach with patients and families to promote positive childhood experiences and relational health. Number 4. Physicians can advocate to prevent ACEs through social programs such as economic supports for families, public education, and early childhood development programs. Thanks for listening.